All right, guys, so this is a three-part talk on the thyroid and parathyroid. Part one is going to be benign entities, including some congenital stuff. Part two is going to be cancer, the thyroid primarily, and part three is going to be parathyroid imaging. So just like in other modules, there's three basic types of questions. Starting out with a what is it question. So here we go. We've got an axial and a sagittal CT. We notice that it's contrasted. That's important. I'll sort of touch on that a little bit more. But the first thing you should do, identify the sequence. It is indeed contrasted. Contrast is clearly seen in the vessels. And then the next thing to do is decide on whether it's cystic or solid. Cystic cases are by far more common. Solid cases are going to be like floor of the mouth cancer and oropharyngeal or nasopharyngeal cancers. So this is a cystic case. Once you've figured that out, then you need to localize it. So here it is. Here's our cystic lesion, and it is around the level of the hyoid. So this is a thyroglossal duct cyst. Now, if you remember from embryology, the thyroid gland starts around the base of the tongue, and then it sort of drips down into the neck. And because of that, there's like a track that exists theoretically. And along this track, you can have remnants, or these ductal remnants, which can form a cyst, or you can have residual thyroid tissue. And within this track, you can develop cancer. So just like you can have thyroid cancer in your normal gland, you can have thyroid cancer along the track of the embryologic track. The way to keep this one straight is that it's midline. It can occur anywhere from the base of the tongue down to the thyroid, but it's most commonly shown right around the hyoid, and it's midline. So here is just a rapid review, this versus that. We've got three cystic lesions here, here, and here. Now, let's separate out location. So the first one is the one that we talked about already. This is our thyroglossal duct cyst. And notice that it's right around the level of the hyoid. Now contrast that to the second one, which is more anterior, sort of sublingual location, right abutting the mandible. And then the third one, which is lateral. So you have two that are central, one that's more anterior than the other. So thyroglossal duct cyst, midline, right around the hyoid. A ranula, which is basically a mucus retention cyst, tends to be in the sublingual space. And the trivia to know is that you call it plunging or diving once it is below the mylohyoid muscle. You don't need to know what a mylohyoid muscle is, what it does, anything about it, just the fact that once it's below that, they start calling these things plunging ranulas. And then the third entity is this lateral thing, this branchial cleft cyst. This is an embryologic remnant that there's a whole bunch of different types, but type 2 is by far the most common. It's like 95%. The one thing to keep straight is that it's not a necrotic lymph node. Remember, you can have like a level 2 lymph node right around this location, and if it's totally necrotic, you might think that it's a cyst. And don't get stumped and think, this patient looks too young to have some kind of a cancer. Floor of the mouth cancers can occur in young people in the setting of HPV. So don't roll that all out completely. Make sure you're dealing with a simple cyst that has no nodules or no septations or anything like that. So again, we've got an axial and a sagittal CT, but this time you notice that it's non-contrast. And I pointed that out because I want you to look at the thyroid tissue, or this dense tissue here, and be like, hey, that looks like that's enhancing. Well, it's a non-contrast study. So why would it look dense like that? You may or may not have ever noticed that on non-contrast CTs, the thyroid looks dense. And the reason it looks dense is because it's full of iodine. Remember that when you give IV contrast, the reason IV contrast looks dense is because it's iodine. Iodine blocks the X-rays. Iodine looks dense. Thyroid looks dense, whether or not you've given contrast to it. So dense things in the neck, especially in a non-contrasted study, are residual thyroid tissue. This orange arrow is pointing to the normal thyroid. So ectopic or lingual thyroid, remember, thyroid tissue starts at the base of the tongue and then drips down, so you can have a glob of thyroid tissue at the base of the tongue, or lingual thyroid, or you can have ectopic thyroid tissue anywhere sort of along that track. And it can get cancer in it, and it will take up iodine. So here's a next step question. If you were forced to pick a next step to confirm that that is indeed ectopic thyroid tissue, you could choose a nuclear medicine test. 123 or 131 would take up the iodine. All right, so here's two ultrasound cases, this versus that, and I'll point out that, so some gamesmanship here. Let's start with the orange one. Notice there are calipers on the isthmus. Anytime there's calipers on anything, it's either too big or too small. You don't necessarily have to remember numbers. Oh, that's too big or too small. If they threw calipers on it, you know it's too big or too small. But in this case, it's too big because you can just tell it looks fat. So putting calipers on the isthmus is a gamesmanship for telling that the thyroid is enlarged. That's thyroid megaly, or this patient has a goiter. Notice that both of them are, both the orange and the red, both have a lot of flow in it. So that's sort of equal. And then on the red, we've got a hypercoic nodule, and then we've also got a heterogeneous parenchyma there on the second lesion. So let's talk about two main entities here that occur in thyroid pathology. Hashimoto's, some people call lymphocytic. This is typically your female, mid-30s, mid-40s, who has low thyroid function and a goiter, as opposed to Graves' disease, which is a high thyroid function. TSH will be low, because remember, Graves' disease is an antibody acting directly on that TSH receptor. They're around the same age. They both can have a large thyroid that's heterogeneous. Vascularity is variable, but let me make a good point here. Graves' disease has a buzzword, this quote, inferno thyroid. So if they show you a ultrasound that has a lot of flow in the thyroid, they're trying to tell you it's Graves'. The trick is that Hashimoto's can also have a very hot thyroid, depending on the phase. Hashimoto's has three basic phases where it starts out hot, you're actually spilling thyroid hormone, and you'll be hyperthyroid. Then it will be like medium level where you can be euthyroid, and then it will burn out and you'll be hypothyroid. For the purpose of multiple choice, you're going to be dealing with a hypothyroid patient with Hashimoto's, more than likely. But it can be, in the real world, it can be hot. And Graves is always hot. But so even though that Hashimoto's can have a lot of vascularity in it, and I showed that ultrasound finding deliberately for that, that finding is something you need to think about with Graves if you're given no other evidence and no other findings. Now, there are two Aunt Minnie appearances for Hashimoto's. The first one is this hypercoic nodule, which some people will refer to as a white knight. This thing, so two things to know about it. One, if they show it to you, it's Hashimoto's. Two, if they want you to biopsy it, you should not biopsy these things. They are 100% benign. Hypercoic nodules in the thyroid are benign. The second finding here is this heterogeneous looking parenchyma, sort of spotty looking. Some people will call this giraffe skin. This is a buzzword for Hashimoto's. Now, Graves' disease can be heterogeneous also, so I think this is less helpful. The one that is more helpful is the the white knight. But if they only show you one picture, just like the vascularity for Graves, if they show you one picture and it's vascularity with no history, it's Graves. If they show you one picture and it's a heterogeneous thyroid that's got giraffe skin, it's Hashimoto's, even though Graves can also be heterogeneous. So just reviewing real fast, Graves' disease, if they show you the inferno, that's what they want. It's more likely to be shown with nuclear studies, which we'll talk about here in a second. And if you're lucky, they'll give you some labs. It's going to have a low TSH. Hashimoto's can have that white knight or giraffe skin appearance on ultrasound. Also could be shown with nuclear medicine. And if they happen to give you any clinical information, even though it goes through a phase where you can have high, medium, and low, it's most likely to be shown in a hypothyroid patient with a goiter. So let's review some thyroid nukes real quick. So here's your workhorse. You've got three basic options: 123, 131, or TEC. All three of them can be used to image the thyroid. So reviewing thyroid physiology real quick, here's your thyroid gland. Your thyroid gland is thirsty, and it drinks iodine. That's sort of its job. It takes iodine up through a symporter, which uses sodium and iodine, and this occurs regardless if you are using a TEC agent or iodine 123 or 131. Where things get different is during this organification, where you're taking iodine and you're sticking it on these molecules. That only occurs with 123 and 131. It does not occur with TEC. And the way to remember that is TEC is different. It's just sort of floating in. It doesn't belong there. But your body recognizes the iodine agents, iodine 123 and iodine 131, as being just like regular iodine. So that's why it's going to get organified. It's going to make a further step. So let's compare and contrast these things real fast. 123, it's got a short half-life, 13 hours. It's got the ideal energy. It decays by electron capture, which all around makes a prettier image. The problem is that it is expensive. So it won't always be used because of that. 131 is a longer half-life, it's got a higher energy, it's a beta emitter, and this high energy tends to make a crappier image, especially when you're using a half-inch thick crystal. It's good for therapy, but not the best for routine imaging, and it's contraindicated with kids and pregnant women. But the good thing is that it's cheap. Now, TEC makes an uglier picture. It's got high background levels. It is good if they've been on a thyroid blocker. And the classic thyroid blocker for multiple choice is this, IV contrast. Remember that IV contrast has a bunch of iodine in it that would compete with other stuff going on, and it can act as a thyroid blocker. So don't forget that one. Another really common multiple choice gamesmanship thing is, what do women do who are lactating? TEC, which has a short half-life, you can resume breastfeeding in 24 hours, one day. 123, which has a slightly longer half-life, you can resume in 2 to 3 days, and the way I remember that is 1, 2, 3, 2, 3, 2 days, 2 to 3 days. And then 131, which has the longest half-life and is the most toxic, you should be terminated your lactation at that point. So here's a normal-looking thyroid uptake scan, and what's done by convention is measurements at 4 hours and 24 hours. So homogeneous uptake, and then you've got around 15 for 4 hours and around 30 for 24 hours. And what's done is a correction, if they would happen to ask, just for completeness, is that background counts are corrected for using the thigh and neck counts for like background. But just remember 4 hours and 24 hours, around 15 and around 30. It's how I remember it, to double it. So what are some causes of a false negative? What messes with the thyroid uptake? So renal function. If you've got crappy renal function, that's going to increase the stable iodine pool. So you've got more physiologic iodine floating around, and that's going to compete with your tracer, so it's going to reduce the counts. Dietary iodine is variable and controversial. I don't think that would be asked. Medications, on the other hand, could be asked. So conventional thyroid blockers, nitrates, amiodarone, and of course, IV contrast. So the two, if you were going to remember anything, well, the blocking agents are obvious, but amiodarone, thyroid, amiodarone, and IV contrast. I mean, they could ask nitrates too. They'll, of course, ask the one that you don't remember. So remember them all. So what about some causes of a hot thyroid, or thyroid that has increased uptake? Graves is the big one to remember. Remember I said that early Hashimoto's can be hot. You can have rebound off of meds. A deficiency in iodine, which is really going to be your person from Africa. But this is your poster boy, Graves. Increased uptake is going to be Graves. So what about a cold thyroid? Burned out Hashis or the late Hashis, which is really the conventional one that people think about. Dequervains, renal failure, and that's sort of a false issue, right? Because you've got two more circulating iodine than would normally have. It's a competition thing. Medications, like I mentioned before, or the opposite, which is an overdose in iodine in the diet. Just remember, if you can only remember one, remember that Hashimoto's is going to have decreased uptake. So if you're given labs and you've got high T3 and T4 and a low TSH, and they show you that, the pyramidal gland, this is Graves. This is a classic look for Graves. Now this guy here is a multinodular goiter, and there's two basic types to think about. The classic one is an old lady with weight loss, anxiety, insomnia, tachycardia, all the things that are making you think that there's a hyperthyroid picture. This is your toxic multinodular goiter, where the gland is heterogeneous, the nodules are hot. Contrasted to a non-toxic multinodular goiter, where you can have hot and cold, warm nodules on a background of normal thyroid. So the nodules are not suppressing the normal background thyroid, and that is a non-toxic one. The toxic one is going to be the one who comes in symptomatic, and that's the one that has the nodules that are so hot that they are suppressing the background thyroid. So just comparing these real quick, Graves is homogeneous, the multinodular goiter is heterogeneous. Graves has a very high uptake, the whole gland is on fire, so you're going to have uptake in the 70s. Heterogeneous uptake in the multinodular goiter, it's going to be sort of medium in the 40s. Now we've got early Hashis. Remember, we're really getting tricky here. Early Hashis can have this homogeneous uptake compared to a burned out Hashis later on that's going to be basically a cold gland. Here's the step one question also, that Hashimoto's has autoantibodies to TPO and this anti-thyroid globulin. So that could be asked. Remember, people who write multiple choice test questions for boards, especially radiology, want radiologists to be thought of as, quote, real doctors. So they tend to be obsessed with stuff like laboratory values and medications and a lot of things that you never use practically because you're not actually a real doctor. You're not a family medicine doctor. I'm sorry. You're not. But you will be tested as if you are one. And remember that Hashimoto's has an increased risk for thyroid lymphoma. That's a highly testable piece of trivia. So here we go. low TSH, high T3, high T4 with a cold gland. This is your subacute or your DeQuerre veins. Typically with this, they're going to give you a history of a viral prodrome followed by hyperthyroidism. And then if you would happen to do a thyroid uptake scan, it's going to be decreased uptake. So in this acute phase, it can mimic Graves'. The difference is going to be the uptake scan. Graves' has a super hot uptake scan. Another trivial thing that can occur, this is zebra, is that you can have ectopic ovarian tissue that can basically be a second thyroid. And if this is happening, that is going to suppress the thyroid in the neck. So let's talk about treating the thyroid. A hyperactive thyroid, that is. So you can zap the thyroid, and the way that they do it is, which you probably have done, is by using iodine 131. Now, dosing depends on the etiology of the hyperthyroidism. A Graves' disease, which is more vascular, is going to get a lower dose versus a multinodular thyroid, which is going to require more dose. And the way that I think about that is the little nodules in the toxic multinodular goiter have little capsules on them, and you need more medicine to get that in there. Versus Graves', which is like super vascular, you need less to get it in there. So 15 for Graves', 30 for multinodular goiter. Some tricks for multiple choice: units. Pay attention to the units, guys. You can mess with those units. Okay, so pay attention to that. And that's pretty much it. Just remember 15 and 30. Now, what about the buggy-eyed dude? What about thyroid eye disease? This is sort of controversial depending what you read. A lot of places are telling you not to treat someone who has thyroid eye disease because it can actually worsen after an iodine 131. If prompted and you're given a choice, I would send them to ophtho first, to depending on the severity. If they pin you down and they want you to try to treat them, then I would say no. And just a real quick review of what thyroid eye disease looks like. Thing to know is that you've got enlargement of the extraocular muscles, and it tends to spare the myotendinous junction, so it sort of looks like a Coke bottle. That's different than pseudotumor, which will affect the entire muscle. The other thing to know is the order, which is there's this mnemonic: I'm slow, inferior, medial, superior, lateral, then oblique. In that's supposedly the order that they occur, in that order. Oh, and the last thing to know is that it's not painful. Pseudotumor is very painful. Pseudotumor tends to involve lateral rectus first. Graves' disease is not painful and does not involve the lateral rectus first. And it spares the myotendinous junction. So, family medicine called, and they want an emergent 131 treatment for hyperthyroidism. So this doesn't exist. There is no such thing as an emergent hyperthyroid treatment. You can always use medications to cool it down. The standard is methimazole. However, if you have an allergy, the patient has white blood cell issues. Remember, a side effect of methimazole is neutropenia. Or if the patient is pregnant, you want to use PTU. And the way that I remember that is P for pregnant, P for PTU. So PTU for pregnant, P for PTU. All right. Lastly, there is this entity called the Wolff-Chaikoff effect. And because it has a fancy sounding name like that it is something that someone who writes multiple choice would probably love. Basically, it's a reduction in thyroid hormone levels that occurs after a large ingestion of iodine. So you can take a massive dose of iodine, and that will basically cause a decrease in thyroid output. It lasts about 10 days, and then it's followed by what's described as an escape phenomenon. I have to talk about that. But large iodine-containing drugs like amiodarone will cause hypothyroidism via the Wolff-Chaikoff effect. All right, so that is the end of this first talk. The second talk will be a cancer nodule talk.